Good morning to our U.S. speakers and our East African attendees. Thanks so much for coming to day 2 of the Global One Health Initiative Summer Institute's Internal Medicine Series in Hematology Oncology. Today we have 3 speakers, Dr. Srinivas Devarakonda, Dr. Austin Sim, and Dr. Edmund Folfak to discuss several topics for you. Dr. Devarakonda will speak about the updates in management of multiple myeloma and plasma cell dyscrasias. Dr. Sim, the approach and indication for radiotherapy in heme malignancies, and Dr. Folfak, advances in urologic malignancies. The way this goes is Dr. Devarakonda will start and give his talk. Near the end of his talk, he'll leave 5 minutes for questions, and we will circulate a evaluation for everyone who's in the webinar to fill out for each of the speakers. There'll be a separate one for each speaker. So without more to do, I'll just introduce Dr. Devarakonda. He's an associate professor at Ohio State in our Division of Hematology. He's an expert in plasma cell dyscrasias, including multiple myeloma, and he is going to provide us with an overview of updates and management of these disorders. And thank you, Srinivas, for coming. I'll hand it over to you.
Thank you, Rob, for the introduction. Let me share my screen. Can you see it okay?
Yep, looks good.
Okay. Good afternoon, everyone. Thank you very much for joining us here today. I'm glad to be speaking to you all again this year. Today, I'm going to talk about the state of art in multiple myeloma and plasma cell dyscrasias. A lot has been going on in multiple myeloma in the last few years. There is an explosion of development of various therapeutic modalities for multiple myeloma, especially the changes in how we diagnose, the changes in how we stage, and also various new developments, sophisticated immunotherapeutic treatment approaches in multiple myeloma. So it's hard to fit everything in 40 minutes. So I'm going to try my best to just give you an overview of the updates, and we'll be happy to take any questions towards the end. I have no relevant financial conflicts of interest. So the objectives will be to briefly talk about the spectrum of plasma cell dyscrasias and to review the updated International Myeloma Working Group diagnostic criteria and revised staging system, to discuss the genetic and molecular testing, to review the role of novel imaging methods in myeloma, to discuss the evidence behind current standard of care, to review the recent data on upcoming treatment options, and to introduce the role of MRD testing in the management of myeloma. So as you all know, multiple myeloma is a clonal plasma cell malignancy characterized by infiltration of the bone marrow and end organ damage, usually mediated by a monoclonal protein. It ranks next to leukemia and lymphoma in hematological malignancies, comprising 10% of all diagnoses. 2/3 of the patients are older than 65 years at diagnosis, so there are a lot of implications in regards to the management because of their performance status as well as medical comorbidities. Various causes have been implicated, mainly chemicals in herbicides and pesticides, as well as radiation. Multiple myeloma is a result of a complex interaction between the plasma cells and various cells in the bone marrow microenvironment, such as the stromal cells, osteoblasts, osteoclasts, and endothelial cells in the blood vessels. So this is historically has been the spectrum of monoclonal gammopathies. MGUS, which is monoclonal gammopathy of unknown significance, wherein you just have an M protein and there is no end organ damage. Patients are asymptomatic. If you were to do a bone marrow biopsy, you would find less than 10% plasma cells. Whereas smoldering myeloma, you do have M protein associated with 10% or more plasma cells in the bone marrow. Even here, patients are asymptomatic. So historically, we haven't treated them. Recently, there has been a little change in how we manage smoldering myeloma in some of the cases. I'll be talking about that in a few minutes. And multiple myeloma, which is active myeloma, wherein you have a sizable M protein, more than 10% plasma cells, and there is end organ damage. So in multiple myeloma, every patient, we do offer treatment. So we've always remembered multiple myeloma as having end organ damage, having GRAP features, such as which is hypercalcemia, renal failure, anemia, and bone disease. However, over time, we've realized that not every patient with a smoldering myeloma is truly smoldering myeloma. If patients have any of these features, any of these three features listed here, their 2-year incidence of end organ damage is 80% or more. And those are clonal marroplasma cells 60% or more, involved to uninvolved serum-free light chain ratio 100 or more, and at least 1 or more focal bone lesion on the MRI. So these criteria have been added now to the diagnostic criteria of myeloma. So if patients have any of these findings, then they are deemed to have multiple myeloma. So to the right extreme here, for multiple myeloma now, you have to have a proof of underlying plasma cell proliferation and 1 or more myeloma defining events. So along with the historical CRAP, we have 3 more features: skeletal lesions on advanced imaging, such as PET-CT, whole body CT, or MRI, light chain ratio 100 or more, and 60% or more plasma cells in the bone marrow. So the new mnemonic is, instead of CRAB, is slim CRAB. Offhand, I'd say you're suffering from an arrow through your head, but just to play safe, I'm ordering a bunch of tests. So what tests do we need to order for the initial diagnostic workup? Pretty much, we haven't changed anything from the past. It's the same diagnostic workup, except now we are using advanced imaging techniques more often than we did in the past, because several studies have shown that just plain X-rays will miss bone lesions and multiple myeloma in at least 35–40% of the cases. Another important thing to remember when you're doing diagnostic workup for multiple myeloma is to order serum-free light chains, because 1/5 of the patients with myeloma secrete only free light chains. So if you don't order serum-free light chains separately, then you're going to miss those cases. And serum-free light chain ratio can be elevated in advanced renal failure from hypertension, diabetes. So ratio of less than 3 is usually more likely to be from chronic kidney disease. Molecular testing plays a significant role in multiple myeloma, and those findings we note from FISH testing. And these FISH abnormalities have prognostic significance with impact on the progression-free survival as well as overall survival. What are the some of the high-risk features? Because there could be some high-risk features that we still don't know. As of today, these are the high-risk features: 17p deletion, which is the mother of all bad prognosis, and anything to do with the IGH translocations, translocation 4, 14, 14, 16, and 14, 20. And recently diagnosed high-risk feature is gain1q. Another addition actually has been deletion 1p. We submitted a study to the ASH last year. The rest of all, hyperdiploidy, translocation 11, 14, they're all standard risk features. How do we stage multiple myeloma? In multiple myeloma, as you know, there are only 3 stages. There is no 4th stage. So the international staging system was a very simplified staging system, I would say, oversimplified, using albumin and beta-2 microglobulin. If the albumin is more than 3.5 or more, and beta-2 microglobulin, which is akin to a tumor marker, if it is less than 3.5, then they are stage 1. If the beta-2 microglobulin is 5.5 or more, it is a stage 3, irrespective of what the albumin is. However, over time, we have realized that this system is oversimplified, because we've seen like several patients with a stage 3 doing much better than a stage 1. So what is that something that is missing, that was missing in the international staging system? That's the chromosomal abnormalities, the high-risk features that I've mentioned before. Multiple myeloma is one of the few hematological malignancies where the prognosis is heavily dependent on the chromosomal abnormalities. So we've added the FISH abnormalities and serum LDH to the international staging system to devise the revised international staging system. So to have a revised international staging system, RISS stage 1, you got to have ISS stage 1 plus not standard risk features on the FISH testing as well as normal LDH. Whereas a stage 3 ISS with either elevated LDH or high-risk FISH abnormalities makes it a stage 3 RISS. A few words about the imaging in multiple myeloma. Bone disease is a major cause of morbidity and mortality. So if you want your patients to have a good quality of life, pay attention to the imaging studies as well as treatment of bone disease. As I mentioned before, bone disease could be missed with skeletal surveys in up to 40% of the cases because of the low sensitivity. Also, X-rays cannot distinguish vertebral fractures due to benign osteoporosis from those related to multiple myeloma. And as I've mentioned, multiple myeloma is a disease of the elderly. So you don't want to misdiagnose benign osteoporosis as bone disease from myeloma. So we do use advanced imaging techniques these days more often. So this is a cartoon showing the comparison of the various novel imaging techniques. I'm not going to go over everything in the interest of time, but a few points. If you're suspecting extramedullary disease, use a PET-CT. If you see a fracture, compression fracture, and you're not sure if it is from osteoporosis or multiple myeloma, apart from biopsy, you can use an MRI because MRI is very good at differentiating them. Also, if you're suspecting cord compression, MRI is your test to go. Whereas if the patient has a fracture and is being planned for surgery, orthopedic surgery usually want a CT scan. The current treatment landscape of multiple myeloma, I'm going to talk under these headings. First, we'll talk about smoldering myeloma and get it out of the way because we don't usually treat every patient with smoldering myeloma. So there was an ECOG trial, Eastern Cooperative Oncology Group trial that was done 5 or 6 years ago, wherein they took patients with smoldering myeloma and they risk stratified them using these risk factors: plasma cell percentage more than 20, M protein more than 2 grams, and light chain ratio more than 20. We call it 2-20-20 rule. If a patient has one risk factor, it was deemed to be intermediate risk, whereas if they have 2 or 3 risk factors, it was high risk. So they took patients with high risk and treated them with lenalidomide, 25 milligrams standard dose and regimen, and the endpoint was progression-free survival. As expected, using lenalidomide reduced the risk of progression into multiple myeloma. However, it was not a free lunch. Lot of side effects, lot of hematological as well as non-hematological toxicity, increased instance of second primary malignancies, and the treatment discontinuation rate due to adverse events was more than 50%. So what is my take on this study? Not every patient is a candidate for this study. I would say probably patients who are fit or younger population with high risk features are the ones that I would offer treatment after having a long discussion about the risks and benefits, especially the risk of second primary malignancies. The treatment of multiple myeloma, we are going to talk first about the treatment of transplant eligible newly diagnosed patients. So as you can see here, there has been an explosion of treatments in multiple myeloma. This was actually like 5 years ago. Now we have even more treatments available. And with these treatments, the overall survival for multiple myeloma has improved significantly. What used to be a median of 3 years, even for standard risk myeloma, now it is 8 to 10 years. And the survival is improving, progression-free as well as overall survival is because of the superior responses with the newer drugs, as you can see here. In the green is overall response rate, and in the yellow is very good partial response or better. So what does that mean? It's not just overall response. More patients are responding to treatments, but also they are having deeper responses. So the standard induction regimen for multiple myeloma has been lenalidomide, bortezomib, and dexamethasone. We abbreviate it as VRD. It was a SWOG trial that showed that a combination, 3-drug combination, is better than a 2-drug combination. Hence, VRD has become the optimal choice in US, and I think like even in many of the European countries, it is being followed now. Where do we use other triplet regimens such as Velcade, cyclophosphamide, and dexamethasone? Only in patients presenting with acute renal failure, because you cannot use lenalidomide in renal failure. However, once the renal function improves and the renal function reaches a steady state, we tend to replace cytoxan, cyclophosphamide with lenalidomide. Carfilzomib is a second-generation proteasome inhibitor. People tried, it has been tried in the frontline setting. There was another ECOG trial that compared VRD versus KRD. However, there was no benefit of KRD versus VRD in newly diagnosed myeloma. Where do I use carfilzomib in the frontline setting? Two main indications come to my mind. One is patients with significant peripheral neuropathy from pre-existing diabetes, or patients who have other indication where you want a very quick response. They have like extensive tumor burden, they have renal failure, you want a very quick response. Those sometimes I use carfilzomib in the frontline setting. Next, we have daratumumab, which is a CD38 targeting monoclonal antibody. Griffin study was the first phase 2 study exploring the role of dara-VRD in transplant-eligible newly diagnosed multiple myeloma. Final analysis after actually 4.5 years showed a significant progression-free survival benefit for dara-VRD. And even sustained MRD negativity. Sustained MRD negativity means being MRD negative over a period of 1 year. 2 tests showing MRD negativity spaced 12 months apart. MRD negativity was superior with dara-VRD. However, 4-year survival, overall survival was similar between the two groups. We have to wait and see if over time the overall survival curves separate. And as such, historically, it's been difficult to show overall survival benefit in multiple myeloma because you have like so many salvage therapies that you can keep the patient alive. However, again, when you are using more drugs, the instance of adverse events can go up. So expected higher instance of neutropenia in the DARA arm. 2 other studies, the Cassiopeia as well as Perseus studies, have shown similar findings. And hence daratumumab emerged as a frontline agent in the management of transplant-eligible newly diagnosed myeloma. So this is a simplified algorithm for transplant-eligible patients who are transplant-eligible patients with good performance status and adequate organ function. Age by itself is not a contraindication for transplant, at least in the United States. So you can use any regimen that you believe in, whether it's VRD, dara-VRD, KRD. After 3 or 4 cycles, do a stem cell mobilization and do transplant, followed by maintenance. There is no role for consolidation treatment in multiple myeloma. There was a big international trial, the BMT-CT and 0702, also called Stamina trial, that proved beyond doubt that there is no benefit with consolidation. How do you manage transplant ineligible patients? So we evolved from the times where we were using cyclophosphamide and melphalan to using novel drugs even for transplant ineligible patients. First trial was a French trial by Thierry Feken. They compared Revlimid dexamethasone continuous to 18 cycles of Revlimid dexamethasone to melphalan, prednisone, and thalidomide. The main finding of this study was Revlimid, lenalidomide, dexamethasone is superior to melphalan, prednisone, thalidomide combination. Also, the longer you give Revlimid dexamethasone, the better. So RD has become a treatment option for frail elderly patients. However, if you think about it, when I say indefinitely giving lenalidomide dexamethasone, you can imagine the side effects from the steroids given in the long term. So there was another European study, actually, I didn't put it here for the sake of time, but there was a European study wherein they compared giving Revlimid dexamethasone indefinitely versus giving Revlimid dexamethasone for 9 months, followed by just Revlimid, and patients did equally well. So you can stop steroids after 9 to 10 months in transplant ineligible patients. Another landmark trial in transplant ineligible myeloma has been the Maya trial, which was a phase 3 trial, which added daratumumab to Revlimid dexamethasone, and it has shown significant progression-free survival as well as overall survival benefit in the recent analysis. So daratumumab with Revlimid dexamethasone has become another new option. Daratumumab with Velcade melphalan is another approved regimen in transplant ineligible. However, in the States, we don't use melphalan in upfront management for either, even for transplant ineligible, because we have other drugs which are less toxic. There has been another trial using isatuximab, which is another anti-CD38 antibody in combination with VRD in transplant ineligible. Here, the endpoint was MRD negativity, and the trial reached the endpoint. Progression-free survival was also a benefit, so it has been added to our treatment regimens for transplant ineligible myeloma. So what do I do differently here? I just don't do transplant, okay? Many of the regimens that are used for transplant eligible are also being used for transplant ineligible. However, I personally tend to prefer triplets over quadruplets in transplant ineligible because they are transplant ineligible for a reason, either poor performance status or poor organ function. So trying to minimize toxicity is the main goal here. This was from Yosemite a few years ago. So the burning question is transplant still a valid option in the frontline management of myeloma? There have been two big studies. One was a French study, IFM 2009, wherein they compared two groups, one who got induction therapy followed by transplant, followed by maintenance, whereas the other arm, everything was similar except they did not undergo transplant. What did it show? As expected, in the transplant arm, the progression-free survival was superior. However, there was no overall survival. As I said before, it is hard to show overall survival benefit in multiple myeloma, but I would take the progression-free survival as well as the MRD negativity advantage that was shown with multiple myeloma, with the transplant in myeloma. The US version of the same study was a determination trial, exactly same strategy and same findings. Transplantation achieved superior progression-free survival. So there are so many debates about whether we should do transplant or not. What is my take? What are the pros and cons that I think? Transplant has unquestionable efficacy. Okay, it achieves complete remission in 1/3 of the patients, and it offers the progression-free survival benefit of 18 months to 2 years, even if you don't do maintenance. And in experienced centers, high volume centers, the treatment-related mortality, transplant-related mortality is very low. And if you think about it, once you do transplant, you can put them on maintenance, sometimes just with one drug, most times just with one drug. Whereas if you don't take the patient for transplant, you tend to continue the induction therapy indefinitely, causing a lot of expenses as well as complications. And transplant offers significant MRD negativity, and availability of salvage options doesn't let us see like overall survival benefits. So that should not deter you from using transplant. And what the two trials have actually shown us was whether you do transplant upfront or whether you do transplant at relapse. In both the determination as well as the IFM studies, patients in the non-transplant arm underwent transplant upon relapse. However, not many patients could undergo transplant when they relapsed, either because they aged or they had like too many comorbidities by then, so they were ineligible. Also, transplant, when done initially, is the best initial package because the disease is still responsive and patients derive more benefit. So how do we determine? The one way that we can decide whether to take the patient for transplant upfront or do it later could be by MRD testing. If the patients achieve sustained MRD negativity response, or if they have sustained MRD negativity, those patients who are young and with standard risk is the main thing. Those are the patients that I would delay transplant. If it's a patient who is on the cusp, the patient is already like 69, 70 years, I don't want to defer because by the time they are 73, 74, they might not be eligible for transplant anymore. Also, if I see a young patient with high-risk disease, I want to take them for transplant to give them the benefit of transplant. If it's a young patient with standard risk, I might defer transplant for later. Tandem transplant is 2 back-to-back transplants. It's not a standard of care practice in the United States. The stamina study, the BMT CTM 0702 study that I mentioned before, did show progression-free survival benefit for tandem transplant in younger patients with high-risk disease. So I actually do tandem transplant for selected young patients with high-risk disease who have good performance. As I said before, MRD detection might be helpful in determining the candidates for a second transplant. Maintenance therapy, it has been shown beyond doubt by several studies, including 3 major studies, the CALGB study, the IFM study, and the Dutch study, that lenalidomide maintenance provides not only progression-free survival, but also overall survival benefit across all groups. However, the benefit is not as strong in high-risk disease as it is in standard risk disease. So median overall survival improvement with LEN in most studies has been 2 years. There is a concern of second primary malignancies with the chronic use of LEN. However, the progression-free survival benefit of 52% outweighs the small risk for second primary malignancies. And the therapy is indefinite. How do we treat patients with high-risk disease? What is the optimal maintenance regimen? We don't know yet. There are several studies being done to answer that question. There was one old study by the Dutch group called the HOVON study, in which there was a subset analysis of high-risk patients who derived overall survival benefit with Velcade. So when I see patients with high-risk disease, I tend to use Velcade for maintenance, sometimes a combination of Velcade and Revlimid. There has been another medication that was tried in the maintenance setting, which is still used, which is ixazomib, which is an oral proteasome inhibitor. However, there were 2 trials, the Tourmaline 3 as well as 4 trials. Both of them showed that ixazomib is inferior to lenalidomide. So where do I use ixazomib? Patients coming from far off areas, they don't have transportation. I want to use an oral agent, but they cannot tolerate lenalidomide. Every time I put them on, they have significant rash or they have like significant DVT history. I tend to use ixazomib. Again, how long? What is the optimal duration? Using MRD status to track the disease would help us optimize the duration for maintenance therapy. Moving on to relapsed refractory disease. Community oncologists often ask me, like, what is the best regimen for relapsed myeloma? What is your recommendation for first relapse? What is your recommendation for a second relapse? That's a loaded question. And there is no one answer for everyone. One size doesn't fit all. But I can help people by telling them like how I make the decision. I take into account 3 groups of factors. One is patient-related factors. What are the patient's preference and goals? Okay, if I'm seeing an 85-year-old patient with a relapsed disease, okay, and they are not in great physical condition, and if they value quality of life more, okay, they don't want to be coming to the hospital, they want to be home, they want to be with their dog, then after all, maybe they are not candidates for treatment and maybe have a discussion about hospice. take the patient's preference and goals into account, not your goal for them, but what is their goal for themselves. Their comorbidities, their age and performance, the frailty index. Don't just make a visual examination or a visual inspection or visual assessment of performance. Use the frailty index, whether it's International Myeloma Working Group or Mayo. Use an objective assessment to determine the performance status. What are the social factors? Do they have social support? You put them on treatment, but is there anyone living with them to watch them if they were to get toxic? And financial, especially with the exorbitant cost of many of these drugs, financial reasons cannot be ignored. And what are the disease-related factors? Presentation is the most important thing. Just yesterday, I saw a lady, she's 70. She had multiple myeloma 20 years ago. And as was the norm at that time, she underwent a tandem transplant. She's been doing great since then. In the last couple of years, she has a resurgence of M protein again. Her M protein is showing up. It's up to 1 gram now, but there is no end organ damage. She's in great physical condition. She bikes every day. Do you really want to treat the number, or do you want to treat the patient? Those are the kind of patients I would call, which is called a biochemical relapse. Sometimes you can watch them. I mean, we did a bone marrow biopsy. It had like less than 10% plasma cells. So sometimes biochemical relapse, you can watch them. You don't necessarily have to treat a number. However, on the other hand, if the relapse is aggressive, causing kidney failure, or it has come back as a plasma cell leukemia, you have to treat them right away. Bone marrow reserve is very important, especially with the aging patients. If they're, say, like 70s, 80s, and they already have baseline cytopenias, that makes a big difference in what I use for treatment. I might not use an alkylating agent in these patients, or even I wouldn't be using something that's going to make the counts go down significantly. And of course, the most important, as an oncologist, science-based is a treatment-related. What have we used in the past for treatment? Okay, what regimens have been used? How did the response? What is the duration that we got? How deep was the response before with this particular regimen? Do they have any residual toxicity? If they still have neuropathy from the Velcade that you gave, you're not going to use Velcade again. Have they had a transplant before? If not, can they undergo a transplant now? Are there clinical trials available? Are there novel agents available in your country, in your region? So, as I said, it's a loaded question. It's a difficult decision. So I created this algorithm myself for ASH 2 years ago. I'm not going to go over this in depth, but basically, like, I divided patients into lens sensitive and having lens sensitive disease and bortezomib sensitive disease. And based on that, you can pick one of the regimens. We'll share the slides with you so you can go through that. Again, this is a list of, I made like 2 tables. One is evidence for lenalidomide-based regimens. The other table is evidence for all your bortezomib-based regimens for relapsed myeloma. So suffice to say, we have a lot of treatment options to choose from. However, oftentimes we do run into problems with the insurance, unfortunately. The insurance won't cover it. They said you broke that same leg when you were 5, so it's a pre-existing condition. So what are the evolving options? You all would have already heard and looked into immunotherapies that are that have made a foray into the treatment landscape of multiple myeloma. CAR T-cell therapies, monoclonal antibodies to various antigens, bispecific T-cell engagers, where we use T-cells to target both BCMA as well as CD3. We are using both the antigens. And what is the emerging role of MRD in the treatment decisions? So currently approved T-cell engagers in relapsed refractory multiple myeloma, we have 2 CAR T-cell products. One is ide-cel, the other is cilta-cel. Ide-cel is approved after 2 or more prior lines of therapy, including proteasome inhibitor, immunomodulator, and anti-CD38 antibody. Cilta-cel is approved just after 1 line of therapy, including proteasome inhibitor and immunomodulator. They don't have to have exposure to anti-CD38, and they should be refractory to lenalidomide. This is at least in the States. We have 3 bispecific antibodies that are approved. One is teclistamab, the other is talquetamab, and the other is elranatamab. So CAR T cell therapy, you all already know, probably the concept is to take out the T cells, engineer them with a chimeric antigen receptor to the BCMA, or it could be to any antigen on the myeloma cell, and you give patients lymphodepleting chemo, just like you would do for an allogenic stem cell transplant or autologous stem cell transplant with melphalan. Here we use fludarabine and cyclophosphamide, and then you infuse the CAR T cells into the patients, and the concept is the CAR T cells bind to the cancer cells and kill them. So comparable efficacies, I mean, there are more studies coming. I just saw another study where the efficacy of these two products is rather comparable. A little difference in the side effect profile when it comes to CRS and neurotoxicity. Cilta-cel causes more neurotoxicity than ide-cel, whereas cilta-cel has putatively superior efficacy. So the bispecific antibodies, they could be to any antibody, any antigen. We have antibodies to BCMA. We have antibodies as well as CAR T cell being developed to another novel antigen in multiple myeloma cells, that is GPRC5D. So this is the comparative efficacy of bispecific antibodies. As you can see highlighted in green, the efficacy is comparable. And you can see we have various options to choose from. This is from Meditation Gardens. This is a cliff in Encinitas in San Diego, California. And it's the garden is on the cliff overlooking the ocean. If ever you visit San Diego, make a trip there. In the last 3 minutes, I would like to talk briefly about minimal residual disease, the concept of minimal residual disease, MRD, because it is changing how we manage, how we follow patients with multiple myeloma, and how we are getting even drugs approved in clinical trials. So what is MRD? MRD negativity means patients are in complete response as per the bone marrow biopsy, plus when you do next generation sequence or flow cytometry on the aspirate from the bone marrow, they don't have even a single clonal plasma cell, whether you check 100,000 cells or 1,000,000 cells. Basically, at least the concept in next generation sequencing is by doing a clonality testing on the diagnostic sample, you're identifying unique DNA sequences that are specific for the myeloma cells. And in the subsequent samples, you look for these sequences. So there have been several studies, actually there are meta-analysis done, which show that patients who achieve MRD negativity have superior progression-free survival as well as overall survival. And the MRD negativity, the benefit you get from MRD negativity is predictive of progression regardless of transplant status, cytogenetics, or disease staging. So no matter what the stage or the cytogenetic risk is, if you achieve MRD negativity, you do better. So MRD status is becoming, negativity is becoming a surrogate marker even for clinical trials. And I foresee a lot of advantages with using MRD negativity, especially for escalation or de-escalation of treatments, deciding whether the patient should get transplant upfront or whether you can defer it for later. And also the duration of maintenance therapy, which is a burning question. So the take-home message today is revised international staging system is to be adopted in the staging of newly diagnosed myeloma. If the skeletal survey at diagnosis is negative, do PET-CT, MRI, or whole body CT. With the new drugs and treatment modalities, the outcomes have significantly improved. Always enroll patients in clinical trials because it is through clinical trials that we have made so much progress. Triplet or quadruplet is standard for newly diagnosed multiple myeloma. In transplant ineligible patients, you can use doublet, triplet based on the patient condition. Current standard of care is indefinite maintenance therapy. Every patient receiving primary myeloma therapy should be considered for bisphosphonates for the bone disease. CAR T cell therapy and bispecific antibodies are new promising therapies even for refractory diseases. Minimal residual disease has prognostic significance in myeloma, and it is becoming surrogate marker for clinical trials. MRD testing could help tailor treatment based on the response, be the new surrogate marker, and pave the way for cure in the future. With this, I end my talk, and I'm happy to take any questions.
Thank you very much, Dr. Devarakonda, for an outstanding session. Really appreciate your work and bringing this forward today to this audience. We do have good time for questions here. And in the Q&A, there's a series of questions from Mariam. Can you see those, Srinivas?
Let me open.
I can just ask.
Yes. I see only one question here, so please go ahead.
So what would you recommend in centers where there's no transplant center? This is in a resource-limited setting, such as is more common in Eastern African regions.
So, I mean, if there is, good question. So there is benefit for transplant more so in resource-limited areas, because as I said before, even if the transplant center is, say, like 100 kilometers away, okay, try to send the patient for transplant, because once you send the patient for transplant, you can de-escalate. After transplant, say the patient doesn't have resources or the center doesn't have resources to do maintenance with novel therapies, you can just observe them. Whereas if you don't do transplant, you have to continue treatment indefinitely, and that would actually cost you more. That would be my 2 cents. But let's say, like, even in far off regions, it's not there. Then after, say, like 8 to 9 months of induction therapy, based on the depth of the response, you can de-escalate it. Just de-escalate to like 1 drug maintenance or 2 drug maintenance based on the risk. That way you can get away without too much expenses. And I see one question by Yared Desalen. Regarding duration of LEN maintenance, we do have limited supply of LEN apart from its increased risk. What do you suggest on this? Continuing until progression may not seem feasible in our setup. Very good question. Excellent question. So as I said, we don't have evidence as to what is optimal duration. So in most of the studies, in the European studies, they did maintenance only for 2 years. I'm not saying 2 years is optimal, but like in those patients, I mean, they got away by using for 2 years. So I would say like 2 is the bare minimum. After that, you don't have resources, then watch them carefully. Off maintenance, watch their markers every 3 months.
That covers Miriam's second and third question, and she had another one that she posted in. How about duration of bisphosphonate therapy for transplant ineligible patients?
Excellent question. So transplant eligible or ineligible, there is no difference in bisphosphonates. And I sit on the NCCN guidelines panel, and we don't have strong evidence as to what is the optimal duration. So what I'll tell you, like what I personally do. At least for the first 2 years, I use bisphosphonates, or at least if it is transplant eligible, until they go for transplant, I give bisphosphonates every month. If it is transplant ineligible, at least for 1 year, I do it every month. After that, I change it to every 3 months for another year. And if they are in remission or better than VGPR, then I just follow it using it every 6 months. But if ever the patient relapses, I start them back on bisphosphonates, because with relapse disease, the risk of having fractures is very high.
Excellent. So I have a question, Srinu. Are there differences? So I see that the various immune therapies target BCMA or CD38, variety of targets. Does there appear to be an ideal target in myeloma, or in at least 1 or 2 subsets of myeloma versus another?
So right now, like the bispecifics or the CAR T-cell therapies, they are mostly targeting BCMA. One other target that is coming up, one another antigen that is coming up is GPRC5D. We don't have like a lot of studies comparing them. I think like in the upcoming ASH meeting in December, we're going to see a couple of studies comparing BCMA and GPRC5D targets. And actually recently, like there was a manuscript submitted that I'm going to review comparing the two. CAR T-cell therapy targeting BCMA versus GPRC5D. So this Science is evolving. We don't know yet.
Great, great. Thank you. I will say something on the side, is that we are working on a plan to bring cell therapy to Ethiopia, and we'll be discussing that this fall in October. So there's could be some exciting times ahead. And then we have one more question. Can you suggest a minimum pretreatment and T-response assessment working up in the resource limiting setting?
So the advantage in multiple myeloma, you don't have to do bone marrow every single time. You can just do protein electrophoresis and serum free light chain assay on the peripheral blood. You don't have to do it. So in the initial, like once you start treatment, you can do it like every month. But say like once a patient has gotten treatment for like 4 to 6 months, you can transition it to every 3 months. That's the minimum, just protein electrophoresis and serum free light chain assay based on whether the patient has light chains and protein or just one. So after the first 6 months, I usually transition it to every 3 months. And that I would continue indefinitely. And if the patient is like chronic follow-up, like long-term follow-up, 2-3 years, then I transition it to can transition it to every 6 months also. And just do like a blood counts and creatinine and calcium. If anything is changing, then you can go to check the myeloma markers.
All right, excellent. I'll just remind our audience here to please fill out the evaluation for Dr. Devarakonda's talk. This was placed in the chat by Eshitu. If you click that, it'll take you right there. And then also, Srinivas, if you could provide your slides as a PDF to circulate, you could just send them to me. I sent an email this morning.
Sure. And in the last slide, like my email address is there. So any questions, feel free to send me an email. And thank you very much for having me today.
Well, thank you so much. Really appreciate your talk.
Thank you.
All right, so we can move on to our next speaker. This is Dr. Austin Sim. He's an assistant professor in the Department of Radiation Oncology. I believe he has joined us.
Hey, good morning.
Good morning. Thanks for coming today.
Oh, thanks for having me.
So Dr. Sim is going to be speaking this morning on the approach and indications for radiotherapy in hematologic malignancies. The way this is going, Austin, is people are just posting questions in the chat during your talk. At the end, we can leave 5 minutes for discussion. And then we also provide a link for each of the attendees to fill out for evaluating your talk as well. Yeah, we appreciate you being here today, and I will stop sharing my screen so that you can get going.
All right, let's see. So there's me. Where?
It's the green box at the bottom.
There we go. Okay. Yeah. All right. So, good afternoon, everyone. Thank you for having me. My name is Austin Sim. I'm the acting director of Hematology Radiation Oncology here at the James. I'll try to be as comprehensive as I can. I was a little bit ambitious. I think this presentation is being about 70 slides or so, so I'll try to get through them quickly but intelligibly. I don't have any disclosures for this talk. Basically, we just kind of want to go over some kind of the modernization of radiotherapy techniques more recently. So this will be in some target delineation and planning, as well as some discussion of late toxicities and kind of the influence of technological advancement on those, and kind of how that changes the risk-benefit ratio and kind of the mental calculus when you're considering combined modality therapy versus systemic therapy alone. Then we'll go through quick run through of different treatment paradigms, going first through Hodgkin's, both early stage and advanced stage, as well as diffuse large B-cell lymphoma, the various roles for radiotherapy and consolidation, salvage, and peri-CAR-T as well. And then some discussion of indolent lymphomas and some updates there. Unfortunately, I did not have a chance to get some slides on for myeloma, but I'm happy to discuss that in the questions. And just a handful of special situations that are also less common, probably less commonly discussed. So really, historically, back in the 50s and 60s, radiotherapy as monotherapy was curative for Hodgkin's disease. But of course, with the advent of multi-agent chemotherapy, this has very much fallen out of favor due to the toxicities of this type of radiotherapy. So this was subtotal lymphoid radiation, which eventually became extended field irradiation. You can notice the doses are still in the 30 to 40 gray range, as these were primarily curative doses with RT alone. Then moving more until the 90s and early 2000s, we had more involved field radiation. So you can see the reduction in both field size as well as the total dose as well. And now we're really more in an involved site or even an involved node irradiation era. And you can also see even further dose reductions from that standpoint. So, with that change, the advent of, CT-based planning, we're doing a lot more volume-based targets rather than field-based treatment. So here you can see, I believe this is a diffuse large B cell involving the head and neck. On the right side, you can kind of see a pre-chemo PET scan, and on the left side, you can see the CT simulation that's done after chemotherapy for consideration of consolidation. And so really the key in lymphoma and volume delineation is taking the pre-chemo disease and delineating a post-chemo volume that takes into account the anatomic locations of the pre-chemo disease while also respecting anatomic boundaries. So as you can see here on this top right panel, you have kind of bulkier lymphadenopathy in the bilateral neck, but a very nice response to chemotherapy. And you can see that we're going to be treating a volume, the potential space where these lymph nodes are, without being a slave to the actual size of the pre-chemo volume. And additionally, here you can see just a couple of lymph nodes lighting up here, but we're still treating the entire lymph node level here just because of setup uncertainty, positioning uncertainty between the two different scans and things like that, contributing to some uncertainty with where the disease actually is at that point. And so historically, these would have been treated with a selection of different 3D fields conforming to the volume, as you can see here, and with different weights coming up with the final treatment plan. You can see here on the bottom right. So this is a much older way of planning that we're not it's really kind of out of vogue at this point. And now with both intensity modulated radiation therapy and volumetric arc radiation therapy, we're able to get very, very nice dose distributions. You can see here carving around the submandibular gland here, as well as kind of around this lymph node region, sparing the thyroid on the bottom left here, as well as the brachial plexus as it comes out on the right side of the screen. Slightly different plan, going to a higher dose for a little bit of a different situation, but you can see we're really modernizing and really kind of finessing the target rather than treating just a field. This is another example of a patient with the inguinal follicular lymphoma. This is an older plan using really just on-phos electrons, kind of wiring an area out and just kind of treating the whole area just from one single field. These days, we'd be able to use arc therapy to really delineate the pre-chemo extent of disease and really carve out of both you have the femoral heads here, you have the bladder, and then carving around the sigmoid and the rectum back here as well. More advanced planning techniques, in addition to changes in dose have really, really revolutionized how we think about radiotherapy, and how it's delivered for these patients. The other thing, this is another kind of great example of the difference in treatment planning. So you can see on the left panel, you have a standard kind of 3D plan using those fields that we saw before. Nowadays, we're using a lot more intensity modulated radiation therapy and now arc therapy. We're routinely using arc therapy for things like craniospinal radiation and things like that. And then, of course, for something like this, the use of proton therapy or other heavy ion therapies and other advanced technologies is a natural fit as well. You can see the dosimetric advantages here from that standpoint. And so why do we do this? Why do we care about volume? Why do we care about, dose organs at risk? And it's really about late toxicity. Because in the grand scheme of things, the amount of dose that you're delivering from the vast majority of these patients is not going to be enough to cause significant acute toxicity, just because the doses are very low compared to what you deliver for a lot of other solid tumors. And so, of course, secondary malignancies, cardiopulmonary toxicities, and endocrine toxicities. And so, as you can see here, this is for a series of patients that were treated in different eras. And so panel C, you can see the cumulative incidence of these toxicities decrease over different eras as we're able to improve both systemic therapy regimens and delivery, as well as refine radiotherapy and how it's delivered. So cardiotoxicity, this is very well known in terms of dose to the heart from radiation. Historically looked at the mean heart dose, the dose that's given to the organ on average. Looking at these two publications, you can see these kind of similar areas, looking at different major cardiac events. And there's actually a kind of a dose relationship, as you'd expect. So for each additional gray mean heart dose, you can see about a 1.5% increase in the hazard ratio. But radiotherapy is not the only thing that we need to worry about in these patients. Of course, the exposure to anthracyclines, the cardiotoxicity of those is also very well documented. This particular data set, it was a much more potent driver of cardiac disease than radiation itself. You can see that it's similarly in a Dutch case control series, you can see the relative risk increase as we get higher and higher doses to the heart, but also benchmarking against the increase in relative risk based on anthracycline use as well. So having those numbers in mind, transitioning to a more modern era, this is analysis of the UK RAPID trial looking at mean heart doses, and the vast majority of these were able to go pretty low. So over half the patients received less than 1 gray, and almost 70% received less than 5 gray. And you can see, this kind of dramatic decrease in mean heart dose compared to the other series, going as high as 20 gray. Excess cardiovascular incidence of cardiovascular disease is only up by 6% over 30 years, and mortality is only increased by about 0.5%. The vast majority of this cardiac, and some of that's contributory through stroke as well. Looking at the pediatric literature from a similar kind of cohort and even more recent cohort, you can see the concomitant reduction in severe and fatal cardiac disease over time. And so compared to the expected rate in an untreated population of about 5%, we're having an increase, absolute increase of about 1.2% over that in the most modern era. And so really this is largely attributed to both optimization of radiotherapy, but also the more widespread use of cardioprotective drugs like dexaroxane as well. So the other thing, mean heart dose is a very kind of rough metric. It doesn't really capture really all the nuance. And so there's additional data really out of the pediatric literature looking at cardiac substructures and analyzing dosimetry to particular substructures. This analysis demonstrated really that actually the dose to the right coronary artery and the left ventricle were drivers of coronary artery disease. And dose to the tricuspid valve and the right ventricle were actually drivers of valvular disease. And so as we become much more sophisticated about dosimetry to these areas, it's going to be very important to be very circumspect about contouring all of these structures and including them in the optimizer to make sure that we're able to, kind of reduce toxicity as much as possible, even as the dose gets even lower and lower. Moving to secondary malignancies, a couple of data sets really spanning kind of the early days of radiotherapy, so a lot of extended field. This original Dutch study looked at, I think it was 2 cancer centers in that area. 26% of these patients received radiation alone and 6% received chemotherapy alone. You can see a kind of striking increase in secondary malignancies over what was expected, kind of translating to about a 1% increase per year, really without any decrement over time. Looking at a similar cohort from the BC Cancer group, this was just in breast cancer. You could see a difference in the secondary breast cancer risk based off of a Mantle field, so a much larger field versus a much more modern kind of small field radiation. And so the other thing of note is right in the middle of that is actually patients that were treated with chemotherapy alone without any radiotherapy. And so, radiotherapy is not responsible for all these secondary malignancies. We must be mindful of that and also take that into account when we're kind of discussing different risks and benefits with patients in terms of additional systemic therapy versus consolidation radiation therapy when we look at these different regimens. Looking at additional data from the US, this is the childhood cancer survivor data up top and on the right. So you can see actually the dose, the concomitant increase in risk of secondary breast cancers from anthracycline exposure for young patients treated with Hodgkin's is also dose dependent on anthracyclines. But when kind of paired with high doses to the breast from radiation, you can see that these risks are multiplicative, even with a very, very high odds ratio when using both anthracyclines and high doses to the breast. This kind of odds ratio per 100 milligrams per meter squared of anthracyclines is recapitulated in this Dutch data set as well. So kind of copacetic across populations. And as as a result of this, this is from the NCCN guidelines for Hodgkin's lymphoma. There's been a lot of work put in to develop lymphoma-specific dose constraints because a lot of solid tumor dose constraints are far and above beyond even the prescription doses that we would use. And so it's very important to use, different goalposts and be very mindful of making sure that you are, kind of playing within the same playing field. And so, in terms of these toxicities, in addition to kind of the standard ones we think about, there's also different dose constraints for secondary malignancies as well. And one other aspect that we don't really think about as much is a lot of these patients are very heavily pretreated with multi-agent chemotherapy in a way that patients with solid tumors are not. And so even at the same dose to an organ at risk, you can have more toxicity than you would expect from treating a patient with a solid tumor. So it behooves us even more to be a lot more aggressive about reducing doses organs at risk as much as possible. And so even though you're using very, very low doses or, kind of intermediate doses, it's still very important to use all the tools that you have from a treatment planning perspective to make sure you're generating the best plan you can for your patients. This is a paper out of MD Anderson looking at 20 gray of involved site radiation therapy and kind of contemporary doses that this group is able to achieve using advanced planning techniques. Not just arc therapy, but also deep and supported breath hold and other types of other techniques and positioning at simulation to really reduce dose as much as possible. So mean heart doses, really going down to less than a gray, mean doses to the breast, 0.1 gray. So just negligible doses. And so making sure that we're doing the least amount of harm we can as we do our treatments. Of course, the key importance of FDG PET causing discordance between CT and PET. So there's data suggesting upstaging and downstaging as well. And it's kind of a key piece of the assessment and kind of how we think about treatment planning. So starting with early stage Hodgkin's, we're moving kind of on to kind of how we use radiotherapy in these diseases. Of course, the EORTC and the GHSG are probably the most common ones we use in terms of risk factors determining favorable and unfavorable for early stage Hodgkin's. The treatment paradigm for favorable early stage really comes from German Hodgkin's Study Group. So HD10 really set the stage and established ABVD 2x2 and 20 gray IFRT as the standard. Nowadays, we've reduced that to ISRT, so involved site, as we discussed before. HC16 basically cemented that and showed that you really cannot afford to omit radiation if you want to have the best chance of tumor control. Of course, the big caveat is that overall survival between all these arms is exactly the same. So the radiation is not going to help patients live any longer. But in terms of optimal tumor control, radiation is not really something you can skip for these particular patients. Looking at some other trials that tried to also emit radiation, COGB 50604, looking at 4 cycles of ABVD versus escalating to escalated BACOP. They considered Deauville 3 as negative on this trial, but as you can see, the progression-free survival at 5 years was actually only 77% for Deauville 3. Which in my mind is pretty suboptimal and indicative that chemotherapy alone is not really enough to hold the fort for these patients. Additionally, you have H10F from the EORTC, and this particular trial, as you may know, the chemo alone arm was actually closed at an interim analysis for unable to achieve non-inferiority. And so this is progression-free survival of the favorable arm. You can see that's inferior to combined modality therapy from that standpoint. RAFL is another trial looking to omit radiotherapy and also kind of de-escalate by dropping the bleomycin. So 2 cycles of ABVD, they have a good response going to AVD. Of course, PET positive, they'll escalate to BACOP. And also add radiation if PET positive after the IPET-6. So in this trial, even in this trial, about 3% of patients on the ABVD arm and 4% of patients on the ABD arm did receive radiotherapy. So this is a bit of a higher risk population, but you can see the overall progression-free survival of this cohort on this trial is still significantly lower than some of the other benchmarks we have from other trials as well. So when I think about favorable early stage Hodgkin's lymphoma, it's really based off of the PET. But true CR, Deauville 1 to 2, I think 20 gray of ISRT after 2 cycles of ABVD is really the way to go. You could make an argument for an additional cycle of ABVD and ISRT to 30 gray based off of H10F. But you would have a little bit of a higher risk patient that would fall into that category. Or ABVD times 2, again, that would not be my preferred way to go from that standpoint. Deauville 3, ABVD, it's still reasonable to consider because those patients did very well on the CLGB study. Deauville 3 is kind of when things start to split. And so in this particular population, I don't know if that I'd feel comfortable omitting radiation. I'm going with a chemo-only route. Of course, for, Deauville 4 and 5, appropriately escalating therapy. And so this is the conclusion from HC16, just saying that even in PET-negative patients, we really can't omit radiotherapy without loss of tumor control. Moving to the unfavorable, just on the flip side of the H10 trial, even though the hazard ratio did CHLOROS-1, it was not demonstrated to be non-inferior. The chemo alone arm. So that was also closed early at interim futility analysis. And so you can see that the hazard ratio is over the non-inferiority margin, making chemo alone in these patients less attractive as well. And of course, we have the RAPID trial that included both favorable and unfavorable patients. So 3 cycles of ABVD up front, and then an IPET-3 with a DOBA 1 or 2. These patients did receive observation or 30 gray. In this case, actually, the 95% confidence interval is outside of the non-inferiority margin of 7 specified in the trial protocol. Additionally, out of 420 patients, 26 in the radiation arm actually did not receive any radiation. And so even though the p-value is not significant in the intention to treat analysis, if you look at a per protocol analysis, the radiotherapy arm is a clear winner in this particular case. Again, the overall survivals between the two groups are the same, so you're not really gaining survival, but I do think there is benefit in additional tumor control from this standpoint in kind of the right selection of patients. HC17, this is a more recent trial looking at 2x2 therapy, so 2 cycles of ABVD and escalated BACOP up front, and omitting or including radiation if there's a complete metabolic response on the IPET-4. In this particular patient population, in this particular trial, there was no benefit, no detriment to omitting radiation, unlike the previous trials. But the caveat to that is you have to be willing to put your patient through escalated BACOP, which we don't do very frequently here in the US. But it is a valid treatment paradigm that would be radiation-free. So for unfavorable, so the stage 1, stage 2 bulky disease, other risk factors, really the preferred way that I like to approach these cases is with 4 cycles of ABVD and 30 gray of ISRT. But of course, HD17 can be an alternative if you do routinely use escalated BACOP. These are all very old chemotherapy backbones at this point. And there's, kind of a brave new world of additional therapies. This was a BREACH trial. It's a phase 2 trial that was reported 2 years ago, looking at unfavorable disease, looking at ABVD versus brentuximab ABD. All of these patients did receive consolidation radiation. So this was not a radiation question. But demonstrating the feasibility of using brentuximab in this population. And then, of course, the flip side to that coin is the NIV-AHL trial using nivolumab. So this actually was 4 cycles of nivo-ABD versus kind of induction nivo, and then nivo-ABD, and then ABD, and then radiation. So both of these arms also did receive radiation. And you can see even with nivolumab by itself, you had a CR rate approaching 50% just with nivo alone, really without any other therapy. And of course, you can see the excellent progression-free survival here of both arms as well. And so both of these trial designs did include consolidation radiation, but I think we're probably moving to a space where we're going to try to drop the radiation from this particular paradigm. So we'll kind of see how that works as we move forward as well. So moving on to advanced stage Hodgkin's lymphoma, there's really not a huge role for radiation. I think Rathwell really defined the old standard using ABVD and ABD, of course, escalating to BACOP if there is residual disease. However, kind of mirroring the other 2 trials that we just talked about, the use of BV-ABD in the Echelon-1 trial, which was published in 2018, and more recently, nivolumab ABD in the SWOG study. This actually was a very interesting study because it also included pediatric patients, so patients 12 years and up. So it was a really, really cool trial that bridged kind of the pediatric data to the adult data in an effort to kind of harmonize, kind of treatment paradigms across age groups. And so in this particular trial, radiation therapy was allowed, but only for partial responses or progressive disease. And of all the patients that enrolled in this trial, less than 1% ended up needing radiation at all. And so, I think that the use of radiotherapy in this particular population is definitely dwindling, and we're not really going to have that much of a role. And then, of course, the other trial that was reported was BRICAD using brentuximab as well. So Echelon-1 didn't have any prospective planned radiation. There were a number of patients on both arms that did get radiation. They was pre-planned in the SWOG trial, but very few of them got it from that standpoint as well. And those are the citations there too. Moving to the relapse refractory setting, really the standard has been high-dose chemotherapy and auto transplant. Looking at patterns of treatment failure after this kind of regimen, only 15% of patients had a unique relapse in sites that were not involved before. Every other patient in this particular analysis had disease either previously involved or previously involved disease and new sites. So that really, kind of focuses in on potential use of radiotherapy because we know where the disease is and it's most likely to come back as a way to help sterilize those areas. Unfortunately, there's very minimal prospective data in this setting, but a lot of retrospective data. Really the ILRA guidelines are probably the most helpful. So there are different considerations whether to consider radiotherapy before transplant or after transplant. They kind of, pluses and minuses of both approaches. So beforehand, maximal cytoreduction is definitely, very attractive. But after transplant, there's a chance that the transplant itself could take care of everything. You might not need radiation at all. Or the transplant will cytoreduce, make the radiation a lot more effective as well. The downside is if they need radiotherapy on the back end, an extended recovery could potentially delay that as well. In terms of dosing, this is relapse refractory, so it doesn't behave quite as nicely as de novo disease. So you see some dose escalation. A true CR, 30 gray, anything higher, would require dose escalation, even up to 40, 45 gray, which were, more in the territory of, other solid tumors at that point. So this brings up in a very interesting question. There's a recent analysis looking at the risk of secondary malignancies after transplant, or high-dose chemo and transplant. So this is the Danish cohort, pretty modern from that perspective. This kind of regimen resulted in, a hazard ratio of 2.3, 2.4 for a second primary malignancy, and an astronomically high hazard ratio for a second myelodysplastic syndrome, or AML, after this high-dose chemo and transplant. Did not really increase the risk for solid tumors, but again, radiotherapy is not really the only cause of secondary tumors. Really have to weigh these risks when we're thinking about additional therapies. And so this is another trial that was reported recently at Astro, Checkmate 744. With this in mind, looking at patients with low risk relapse refractory Hodgkin's. This is more of a pediatric population with maximum age of 30. But we can still learn some lessons from this. So low risk as defined below, you can see there. So they underwent induction with BV-Nivo up front. They had a complete metabolic response, 2 more cycles of BV-Nivo, and then underwent involved site radiotherapy to 30 gray. If they had a partial response, they were escalated to bendamustine and ISRT if there's a CMR at that point. So a small cohort, even though it was done prospectively, 93% of these patients did receive a complete metabolic response with fantastic event-free survival and progression-free survival numbers for patients in the relapse refractory setting. So a very interesting use of radiotherapy here and potentially expanding from that standpoint. With the advent of all these novel therapies, what do we do with them in terms of the radiation? So there's emerging data on initial safety of concurrent therapy. This is a small cohort out of MD Anderson looking at concurrent radiation with brentuximab. The caveat to this is that about half of them only receive skin-directed radiation, so very superficial, with very minimal interaction with, systemic agents likely. And then about a quarter of patients also received additional systemic agents in addition to the brentuximab together. It did increase kind of low-grade hematologic toxicities, and there was also a spike in liver function changes as well, but again, grade 2 from that standpoint. So it looks like a minimal change to the toxicity profile, but another reason to be very circumspect when planning your radiation in these scenarios to reduce the risk of hematologic toxicity as much as possible. So trying to reduce the amount of bone marrow in the fields, dose to the bone marrow, and then there's some data more from the lung literature reducing the amounts of large blood vessels in the area to reduce the amount of blood flow that you're irradiating as you pass through as well. Slight switch to nodular lymphocyte predominance, formerly known as Hodgkin lymphoma, but now is B-cell lymphoma, which actually more represents the disease. So this is kind of an exception to the rule. Typically, if it's localized, it's a disease where upfront radiotherapy is recommended. Really only resorting to systemic therapy if there's bulky disease and or more advanced disease. The big caveat and the big thing to remember is when you're using radiotherapy alone for these types of diseases, the margins you have to use for your clinical target volume to cover microscopic disease are much, 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 much larger than you would consider for a consolidation case. Consolidation, you have the chemotherapy that likely takes care of the majority of the microscopic disease. So I typically use about 1 centimeter of margin around residual areas and all of the pre-chemo extent to plan my kind of target volume. In these scenarios, typically I'll take the gross disease and add up to about 3 centimeters and carve off of the anatomic boundaries to make my final target volume. So it's very important to not lose sight of that. So non-Hodgkin lymphoma, really the value is established some older trials in the CHOP era. And kind of recapitulated in some of the newer trials. Again, these are still quite dated, but showing the benefit of radiation there. This is another scenario where can we use more chemotherapy to abrogate the need for radiation? You can see that the LYSA trial, this is the one that's cited quite a bit, using plus or minus consolidated radiation after initial therapy, really without that much of a difference in event-free survival at 5 years. However, we all know that radiotherapy and its effectiveness depends on the amount of gross disease going into the trial. 20%, almost 20% of patients really didn't have any disease, measurable disease at study entry, and there's no info on size of the tumors as well. Additionally, nearly half the patients actually got 6 cycles of R-CHOP rather than 4. So, kind of setting up as a 4 plus or minus radiation isn't really a fair comparison. And delving more into patterns of treatment failure, there were 0 local failures after radiation, but 5 out of 13 local failures happened after chemotherapy alone. So just some caveats to that particular trial. Looking at more modern trials, with the FLIER trial using R-CHOP times 4 plus rituximab times 2, so 6 cycles of rituximab total. Was not inferior. Again, this is not bulky disease. And of course, a SWOG trial recently reported out as well, showing R-CHOP times 4 as sufficient and potentially sufficient in a lot of these patients. Only 11% of patients had a positive IPET requiring radiotherapy. But patients with Deauville 3 did a lot worse than your standard Deauville 1 and 2 patients. So recapitulating a lot of the same ideas from the Hodgkin's data, suggesting some more nuance than is necessarily reported. And of course, in terms of distribution of sizes of tumors, it's not clear how many were borderline bulky, so right under that versus much smaller. I believe if you look at the actual breakdown, a lot of these tumors are on the smaller side and less approaching kind of that more bulky top line, even though they allowed for higher or larger tumors, there really weren't that many of them to really show a benefit of radiation. So for bulkier advanced disease, Unfolder was long awaited, finally reported. Did show pretty good improvement in event-free survival with radiotherapy, such that the non-radiotherapy arms were actually closed early. But we read the actual paper, the conclusion states that the benefit in event-free survival isn't really relevant. Basically, this is pre-PET, and so there were some lesions that may have been a PR, but we couldn't tell without PET. And so they took those out, and the residual benefit in what they call progression-free survival was no longer statistically significant. but they weren't particularly powered for this sub outcome. So I don't know if that conclusion necessarily follows from the data. And then, of course, the RECOVER trial is the other trial. This was really more of a chemo trial looking at CHOP 6 cycles versus 8 cycles of CHOP plus minus rituximab. There was a cohort that did not receive radiation. Those patients uniformly did worse in terms of event-free survival, progression-free survival, and overall survival if the disease was bulky. These are all kind of two nice companion trials as unfolded over younger patients under the age of 60 and RECOVER patients who are older. And of course, the other area where we definitely recommend radiotherapy is in patients with skeletal involvements based off of the HELD data. So definitely a benefit there, even in this era. In terms of dosing, the Lowry study did show really not much of a difference and not much of a benefit to dose escalation. So 30 gray really should be the standard. Unless you have bulky disease, those trials were done with a total dose of 36 gray. So it's another consideration from that particular standpoint there. In the relapse refractory setting, looking at second line, greater than 12 months out, typically patients are evaluated for transplant. And you could kind of use the peri-transplant radiation like we did in Hodgkin's lymphoma. The doses are a little bit higher than what you would expect for Hodgkin's disease, just because it's more aggressive lymphoma there. If they're not a transplant candidate and have limited disease, you can consider curative intent radiation. This doesn't happen very frequently. And then, of course, if it's an early relapse or primary refractory, then we kind of go into CAR T and bispecific territory there. The role of radiation at that point is either bridging or consolidation and salvage. So this is CAR T. Looking at the seminal trials of CAR T, you can see the majority of patients actually will have recurrence. And so what can we do to save these patients from recurrence? So when we looked at patterns of treatment failure, we saw very much like in the transplant data in Hodgkin's, the vast majority of patients experienced a treatment failure in an area that was pre-existing. And over a third, that was their only site of disease. And high-risk features include bulky disease defined as 5 centimeters in our study, as well as the SUV max and an extranodal location. And the other thing that fell out was the prognostic value of metabolic tumor volume, which is also being used more frequently in the heme world. And so compared to patterns of failure after R-CHOP, you can see 44% had a component of local failure in this particular study as well. So how do we use radiation in this paradigm? We were the first group to really describe bridging radiation therapy prior to CAR T in between apheresis and infusion, demonstrating it's safe and effective at debulking, but also maintaining performance status to get patients to CAR. The timing can be quite challenging without a very good multidisciplinary team. So it's something that needs to be worked out from a logistical perspective. And then also, of course, can be used in the salvage setting as well. We found in our data that bridging had better local control compared to salvage, and that patients that were selected for bridging actually had a lot worse disease. And so really what we were able to do is, despite patients coming in with worse disease, expected to have worse outcomes, we're able to neutralize some of that and bring patients back up to where they would be if they didn't have some of these adverse features. And the MSK group was also able to recapitulate those data as well. Our first initial abstract showed a signal with high dose radiation. So an equivalent dose in 2 gray of at least 39 gray. You can be done in a variety of dose and fractionations. We typically pick a 15 fraction regimen if we have time. Sometimes we do a 10 fraction regimen if we have less time. We can see maybe a hint of improvement of local control with some dose escalation, but definitely in line with first principles from that standpoint. There's another line of thought using low dose radiation as a way to prime the immune system to bring the CAR in. And so those data are still maturing as well. We also had an initial signal of the benefit of comprehensive radiation, but of course, this also runs into issues with stage confounding as well. After that, the Mayo group has put together this nice paper showing comprehensive bridging to patients with less than 5 sites of disease. showing a benefit to both relapse-free survival and event-free survival. These patients did receive a lower median dose, some kind of at the top end in the 40s, but some even lower palliative doses. Despite that, they're still able to get a benefit from this standpoint. And then the other piece where the Mayo Group has also done some great work is in the consolidation phase. So if you have residual disease on the day 30 PET, using radiotherapy, if it's localized disease, to help consolidate and make sure that we're having, optimizing responses. There's some other data from Andy Anderson that shows that the use of bridging radiation and all of that doesn't really interfere with CAR T expansion as well. Those data aren't here. Quick foray into indolent lymphoma as well. So for follicular, not a lot of prospective data on the use of radiation. This is a retrospective multicenter series from the ILROG, or the International Lymphoma Radiation Oncology Group, showing patients that are staged with PET that actually have demonstrated stage 1 disease using radiotherapy alone has resulted in very, very high rates of local control with very, very few infield or marginal relapses. You can see a variety of different radiation techniques were used in this particular series. Freedom from progression, 70%, right around 5 years for stage 1, for all comers, and then stage 1, stage 2, you can see the difference there as well. So, really using PET in this cohort to really identify patients with truly localized disease that would benefit from curative radiation rather than observation or systemic therapy up front. Again, going back to the Lowry data, this also looked at indolent lymphomas. Really long story short, no benefit to dose escalation, and so really 24 gray and 12 fractions is kind of the top line that I would use for these particular patients. But how low can you go? Which is very interesting kind of flip side. So this is the FORT trial looking at follicular lymphoma and marginal zone lymphoma out of the UK using a ultra low dose regimen of 4 gray and 2 fractions, or as we technically call boom boom, showing inferiority to a 24 gray regimen, which is not unexpected. But really the key piece of this that's very interesting is that with just 2 treatments of 2 gray each, we're able to get 70% local control over 5 years. So even with just very, very low doses, we're able to get very great, very, very good control. So even for palliative intent or even for definitive intent for patients that are having trouble going to places, coming to your center, all those sorts of things, this is a very, very good option for patients with indolent lymphoma. And I use this routinely in my clinic. And so when we go into marginal zone lymphoma, the group at MD Anderson has really stretched this to the next level, developing risk-adapted radiotherapy. So starting with just the 2 fractions, seeing how patients do, and adding in the additional 20 if we need to, if there's a partial response. So the initial data set was in orbital marginal zone, or orbital malts. And they were able to achieve basically a 90% local control, 90% CR rate with no grade 3 or higher toxicities using this approach. And then more recently published where it's using gastric malts. So it's a much smaller cohort, but 5 out of 6 patients had a CR after just 2 treatments, which is pretty remarkable. The 3-year local control rates, and again, basically no toxicity from that standpoint. So really exciting way to really, really move the needle in terms of toxicity management and disease control. The only thing I don't like about ultra low dose radiation for gastric is to do the surveillance as an invasive procedure. So you need to do an EGD pretty regularly to make sure that they get to a CR, and that's kind of much more of a challenge than doing serial MRIs in my calculus. I think in your area it might be equally as difficult to do serial MRIs for surveillance too. But in the right patients, even 2 gray is just is fantastic for all of this. And then some notes about planning for orbital malts. We typically treat the whole orbit. It's a conjunctival malt. We can just treat superficially and actually spare the posterior optic nerves and the posterior orbit. And really the driver of dry eye in these patients is not dose to the lacrimal gland. What you really need to spare are the meibomian glands, kind of hidden between the eyelashes. So kind of like the submandibular glands provide kind of the intrinsic salivation, and the parotid glands are only activated to provide more in certain circumstances. I kind of liken that to the meibomian glands providing the kind of baseline moisture for the eye, and lacrimal glands only providing additional if necessary. For these patients, I almost never do bolus to really reduce dose to the surface there, preserve those glands. And then for gastric malts, of course, nothing by mouth, using a 4D CT to capture, kind of the whole area where the tumor would be. We typically treat the whole stomach as well as the first part of the duodenal bulb. We're doing treatment planning for these patients. Leukemia, there are limited uses for radiation in leukemia, including myeloid sarcomas or chloromas. These can kind of pop up really anywhere, and can be independent of marrow involvements. As a patient that I treated with leukemia cutis, so cutaneous manifestations as well. So these, even though they might be asymptomatic, really need to be controlled because they can serve as a nidus to reseed the patient and kind of reseed their marrow. For all these, again, we treat these like an indolent lymphoma, so 24 gray for these types of cases. With CNS involvements, we also routinely do craniospinal irradiation. We typically do this using VMAT, as we discussed before. Vast majority of these patients will receive IT chemotherapy, but if they have bulky or symptomatic disease, or if they have cranial nerve involvement, it doesn't usually clear quite as well. With IT therapy, we definitely use radiation in these scenarios. Of course, with the potential interaction with methotrexate and also with cytarabine, it's very important to have, very good lead time between the use of IT therapies and radiotherapy to reduce the risk of myelopathy. There's some data looking at focal radiation, so you can see the base of skull fields versus comprehensive. So this Walker paper looked at, actually showed inferior outcomes using focal radiation and better outcomes using either craniospinal or whole brain. So unless it's truly palliative, I don't typically like to do more limited fields and do something a lot more comprehensive for these particular patients. You can see the difference in progression-free survival in the CNS. 12 months. And then the other thing you can consider doing is if these patients are going to transplant, using this as a bridge to transplant, it's feasible. It's kind of a logistical challenge, but it's feasible to combine craniospinal and roll that directly into total body irradiation in preparation for a transplant. So we've done that before as well. So this Gunther paper in Practical Radiation Oncology goes over some of those considerations too. So the patient that I treated, she had cranial nerve involvements there, and this paper has a really nice kind of atlas in terms of contouring for a craniospinal case. Primary cutaneous B-cell lymphomas, follicle center or marginal zone, typically treated definitively with a generous margin, 24 gray, sometimes to 30, most of these just to 24. Diffuse large B-cell leg type is a much nastier form of a cutaneous lymphoma. These need to be treated like a diffuse large B-cell. They don't typically respond quite as nicely as a systemic diffuse large B-cell, and we typically go to a bit of a higher dose for radiation for that standpoint. This is a nice ILROG guideline on primary cutaneous lymphomas as well. It's a patient with primary cutaneous follicle center B-cell lymphoma I treated with electron therapy. Did result in significant epilation, but this was, even a month after therapy, this thing had disappeared. Great responses with low doses of radiation. Primary mediastinal B-cell lymphoma, historically, we had a little bit of a role for Deauville 4 disease in the setting of RCHOP. But a lot of these patients with serial PETs, their signal actually normalizes and they don't need radiation therapy. And then hot off the press, last couple of weeks, the IELSG37 trial was fully reported out, which showed that if you have a Deauville 1 to 3 response after 6 cycles of RCHOP, these patients do not benefit from radiation therapy. And so really, whether you use RCHOP or dose-adjusted R-EPOCH, The role of radiotherapy is limited to persistent disease, so DOBO 4, DOBO 5 disease. And there is an ongoing trial in HL 1931 using nivolumab. So we'll see what that reports out as well. I also see a lot of patients with mycosis fungoides. We do a lot of spot treatments, palliative treatments, typically 8 gray and 2 fractions. And we also do a decent amount of total skin. At this point, total skin, low dose total skin is really the way to go for the most part. So really going to 12 gray. There's lots of different fractionation schemes. We typically do 2 gray per fraction twice a week over 3 weeks. The Mayo group published doing 4 gray once a week for 3 weeks. So they're different flavors. And I don't know that we have a ton of data to say one approach is better than the other. There are very few situations where we're doing high dose total skin to reduce toxicity and time on the machine from that standpoint. The one exception, this is a spot treatment that I did. So he actually got 12 gray and 3 fractions. Because of the convexity of the scalp, we actually ended up creating a customized bolus and using an ARC therapy plan to treat the skin. This is a response 1 month out, so he's been doing great. The one exception to the total skin story is in the setting of a transplant. And so we're increasingly doing these allo transplants as an attempt for cure in some of these patients. In these patients, we will do default back to high dose total skin. We don't typically do it conventionally fractionated. There's some unpublished data out of MD Anderson going to 28 gray, 2 gray per day, 3 days a week to accelerate the delivery radiation over about 4.5 weeks instead of the traditional 9 weeks to get them to transplant faster. But it's a tough regimen. There's a lot more toxicity and need to monitor patients a lot more carefully. So something that we're still figuring out. And that's all I had. Sorry, I know it was a whirlwind tour and I went through a ton of information really fast, but I did some of the slides, so I have them for reference, and then I'm happy to take any questions.
Thank you very much. Wonderful talk and incredibly comprehensive. And thank you for sending your slides. I'll pass those on as well. That's a great resource for our audience. Eshitu will be posting a form or a link in the chat for your evaluation for Dr. Sim. Because of time, we're going to move on to our next talk. I want to thank you, Dr. Sim, for providing such a high quality talk. And if you have questions, you could send Dr. Sim an email, and he'll get back to you.
Yeah, absolutely. Happy to chat further. Welcome emails. I definitely speak to people across the country all the time. There aren't a ton of us that treat lymphoma, leukemia, so we're a pretty tight-knit community, and we try to work together.
Excellent. Well, thanks very much. We will move on now to our final speaker for the series, Dr. Edmund Fulfak, who is an associate professor in our Division of Medical Oncology at Ohio State. Dr. Fulfak is a medical oncologist who treats patients with solid tumors, and he's going to discuss advances in urologic malignancies today. Dr. Fulfak, just to give you an update, people post questions, chat, and the Q&A. We will also provide a form for our audience for an evaluation at the end of your talk. So again, I appreciate you, Dr. Fulfak, being here today and providing your lecture. I'm going to stop sharing my screen and allow you to do that and take it over.
Thank you, Dr. Bayerke, for organizing this very important lecture for the lecture series. And I think, can you see my slides?
Not yet.
Huh. What about now?
No. We see you.
Oh, okay. I see why. Anything now? It's showing me shared.
Do you have two monitors?
Yeah.
So when you hit share,
Ah,
you may need the other screen. Select the other screen.
Screen 2. Okay. How about now?
Yeah.
This is crazy. Like, what is going on? This is screen 2, screen 1, share. It still doesn't show up.
No, we're just seeing your camera.
I think I'm still seeing global one, whatever. And you still sharing something? Because I'm trying to share the screen and it tells me even when I have screen 1 and screen 2 shared, it's still telling me that I mean it's just, yeah, I can see everybody, but I can see shared screen, and but I don't understand why it's telling me that I'm sharing.
I think you might be. There you go.
Okay. All right. So something. All right. Good. Can you see
Perhaps
me now?
perfect.
Thank you. All right. Once again, I think this is going to be a little bit of to the force. I just it's I have I've picked up 3 cancers the GU space to be able to talk today, and just in the advanced setting. And I know a lot of the people watching this, sometimes some of the things that we'll discuss may not even be available locally, but at least for those in training, and just also being aware of what is available out there. Hopefully one day we may be able to get this okay, all right. Sorry for that. I have to start at the beginning. Boy. Okay. All right. So first off, again, we start with prostate cancer. And as Dr. Bayaki said, I'm an associate professor here, and I'm also the co-director of the fellowship training program here. So prostate cancer, metastatic prostate cancer, I divided it into 2 distinct group, what we will call the castrate sensitive or castrate naive. And this actually is people who have not been previously exposed to hormone therapy, or people who have been exposed to hormone therapy and their disease is still responding to hormone therapy. If you have these patients, then there are a couple of lines of therapy available. Historically, we'll just do androgen deprivation therapy or ADT alone, but currently we only do that for frail patients or people in places where there is very limited access. But more contemporary treatment options would include an androgen deprivation therapy or ADT plus chemotherapy such as docetaxel. You give a total of 6 rounds of chemotherapy, docetaxel, which are given once every 3 weeks. And then at the end, you drop the docetaxel and then just continue with the ADT until disease progresses. The next treatment option is ADT plus either abiraterone, enzalutamide, or apalutamide, darolutamide. These are all what we call secondary androgen pathway inhibitors. And if you use this option, you would need to use this combinatorial therapy for as long as the cancer is responding. And sometimes because of cost, this may really be a limiting factor in terms of choosing this therapy. And then the other option is what we now have come to call the triplet therapy, which is androgen deprivation therapy, docetaxel plus darolutamide. I would say that both ADT plus docetaxel, or this third combination, which is ADT, docetaxel, and darolutamide, these should be reserved for patients with high volume disease. And by high volume, we mean, if you're looking at somebody with more than 4 bone mets, one of which is extra axial skeletal, or people with soft tissue disease. Because studies which utilized abiraterone and ADT plus docetaxel alone, so-called chartered study, or this triplet therapy, most recently done, didn't really show significant improvement in those people with limited stage and limited burden or low burden disease. Now, the other thing that we do nowadays is actually also to use radiation of the prostate. And the whole theory behind this is that if you use radiation to radiate the primary site of disease, that is the prostate itself, where the disease is coming from, that it would not, it would prevent the crosstalk that normally happens between metastatic sites and the primary site of prostate, which is the prostate in this situation. Again, the data here is really strong for people with limited, with low burden disease. And if you do that, you could also consider radiating the metastatic site. And then, of course, if you, and then treat the patients with either ADT plus secondary androgen pathway inhibitors, or chemotherapy plus ADT. In here and in our institutions and other places where clinical trials exist, we always encourage people to enroll in clinical trials, because that's how we developed new knowledge. Now, if the patient progresses on from the castrate sensitive to castrate resistant, yes, a lot of these other options are still available, but it just depends. So you now have to sequence. But one thing to note is that all these agents that we collectively called secondary androgen pathway inhibitors, i.e. abiraterone, enzalutamide, darolutamide, that the cross resistance amongst all of them is about 85%, meaning that if you actually started out using abiraterone in a patient, and that patient becomes resistant to abiraterone, even though it acts differently from enzalutamide, you're probably going to have only about 15% response, and the duration is usually not that long. So you're better off if you used, if you started out with ADT plus either secondary androgen pathway inhibitors, and the patient progresses, you're better off going into to do chemotherapy. And if you started up with ADT plus docetaxel, for instance, and the patient progresses, you're better off going switching to to either abiraterone, enzalutamide, or whatever is available at your center. And the other thing I would mention here is that there is a group, as we're going to see, as these cancers progress, they acquire different mutations. So sometimes they may acquire homologous repair deficiency, or DNA repair deficiency mutations, i.e. BRCA2 predominantly, but you could also have BRCA1 and a host of others. In these patients, then they could be, candidates for PARP inhibitors such as olaparib. If you don't have olaparib, sometimes, chemotherapy with carboplatin could become very sensitive. It could be something that you could consider. And in patients with low burden disease who are castrate resistant, then we could consider a treatment called sapolocel-T, which is itself a form of immunotherapy, and we'll see a little bit about it going forward. And then here also we in places where there is access, sometimes if those patients are become castrate resistant and they have gotten secondary androgen pathway inhibitors and chemotherapy, then you do a PSMA PET, which is and it is avid, then they could actually benefit from a radio ligand therapy called lutetium. Here we'll call it Pluvicto, but it is lutetium 177 vipivotide, detraxazectan. And the last one that I will mention here also is radium 223, which is also otherwise called Xofigo in some places. Again, I'm sure a lot of these things may not really be available, and increasingly also clinical trials become very, very useful in this space. Now, just going back to history, as you see, prostate cancer is addicted to hormone, and how does the hormone get produced? I mean, to testosterone, and how does testosterone get produced? Your pituitary generate the gonadotrophin-releasing hormone, which then instruct the testis to produce testosterone, and the testosterone then feeds the cancer. And as you can see here, this is about 90% of the time. Sometimes about 10% may come from adrenal gland. But I should also mention here that sometimes the cancers can synthesize indigenous testosterone-like chemicals from fats, and that is how they may use to be able to overcome the testosterone. The testosterone blockade. And so when you use things like leuprolide or any of the gonadotrophin-releasing hormone analog agonists or antagonists, you're blocking here. And then if you use things like Casodex or bicalutamide, which are androgens, you are blocking this pathway. And abiraterone would block this production from the adrenal glands. And other drugs like darolutamide, flutamide, and enzalutamide, sometimes they block the conversion of the fats into testosterone like chemicals. And this guy who in 1966 first proposed this idea of the hormone of prostate cancer being addicted to hormones, Charles Hawkins received a Nobel Prize for this great work. And I always like to say, the relationship between prostate cancer and testosterone is like the relationship between the car and the gas. And gas, or in some places in Africa, they may call it petrol, and in which way the petrol, in this case, is the testosterone, which fuel the cancer, and the PSA is like the exhaust. So you can use PSA as a good measure, to be able to assess, treatment responses. And usually, if the PSA is responding quite well, it means that the prostate cancer treatment is also going well. It is sometimes in very rare cases, you may have a discordance where the PSA is no longer still responding and very, very well, still low, but then you see that you find disease progression, and sometimes very rapidly for that matter. And this is why when you're monitoring these patients, wherever possible, it is good to be able to do things like bone scan, if you have them available, CT scans, if patients can afford, again, and then, or here increasingly, we are beginning to use more of the PSMA PET scan. And sometimes you will find an explosion, a disease that is rapidly progressing, which despite the PSA being very low. And in that case, most often it is because the disease has acquired a different mutation than most, and the most common one is transformation into small cell, prostate cancer. And I just put this here to actually show you that androgen-dependent prostate cancer and androgen-independent prostate cancer are really two different disease in some ways. So here you can see that the whole pathway here, you can block the androgen, and then the cancer would eventually starve itself to death. But here they have acquired different pathways as they are mutated. Maybe the androgen receptor no longer is actually mutated in a way that the anti-androgen can no longer bind. Maybe, they have acquired other pathways such as the PKI3, AKT, and then maybe the neuroendocrine pathway, which I just explained to you. And sometimes other, they can de-differentiate. And I also put this for learners so you be aware of what may be coming down the road, because oftentimes we start by understanding the science, and then from the science, we then develop new medications. So you can see the different pathways that are now increasingly that are now available to us in terms of our understanding of how prostate cancer may evolve from androgen dependent to androgen independent. And as I did mention, we now have this population which we have very good treatments, the PARP inhibitors, which we call the DNA repair pathways. This has become really a game changer in the clinic for some of the patients with this mutation. And one thing to note here is that if available, genomics become a good thing for you, a good tool for you to use to test for this BRCA. And going from early prostate cancer into the castrate resistant space, the percentage of BRCA or this DNA repair protein mutations increases, such that in the early stages it may be as low as 5%, but by the time you get up to the castrate sensitive space, it's about 12-13%, and by the time you get to the castrate resistance, you are looking at about almost a quarter of those patients may have these mutations, meaning it may be very, very important to use to check for it. And I just put this slide here just to give you some context about some of the studies that led to the data that we're presenting. The Chartered study was the study that looked at the 6 echoes of docetaxel in what we will call early docetaxel plus ADT compared to ADT alone. And if you can see here, they divided it into high volume and low volume disease. And then the ADT plus docetaxel, which is the yellow one here, really did much better and extend the overall survivor at the time from about 17 months to close to 49 months. And this is where we had this is where we got the data that we're now using for early docetaxel in this patient population from. And Latitude actually compared abiraterone plus ADT versus ADT alone in the same patient population. But unlike Chartered, Latitude showed improvement and overall survivor by similar amount in both high volume and low volume disease. So if you have both low volume and high volume, you could use abiraterone plus ADT. But if you had to use chemotherapy, early chemotherapy, be sure that you are only selecting the high volume disease. And other studies, in this case, the Anzamed and increasingly darolutamide, apalutamide, like I told you, they've actually almost shown a very similar outcome like the abiraterone data. So if you have whatever you have, a secondary androgen pathway inhibitor that you have at your center, which is affordable to the patients, you should combine that early on with ADT whenever possible. These were the very early data that showed the TAX 237 study, and then the SWOG 9916, which showed the improvement in the survivor of docetaxel over what used to be used at the time, which was the mitrozantrone. And mitrozantrone is still something that you can consider if you get to a space where you don't have any other treatment option late in the game of treating these patients. And cabazitaxel is also like docetaxel, but it targets it does have activity, i.e., improve outcomes and responses in patients who have become resistant to docetaxel. And here, the TROPIC study was the study that actually showed, that benefit. And abiraterone, as I told you, could be used either in the pre-chemotherapy or post-chemotherapy, but now increasingly being used with chemotherapy. You can use it with chemotherapy, even though the study now is showing darolutamide, but all these drugs behave just about the same. So again, knowing the state of things in Africa, where you may not have access to some of these new drugs, or maybe pricing may be a very limiting factor for you. If you, whatever you have, you could be able to, gain on this data, extrapolate and use it for the patient population. And in the pre and post, there was the so-called Cougar 301 and then 302, which showed the pre and post abiraterone, chemotherapy abiraterone, as being superior to just the standard of care at the time. Enzalutamide similarly had the PREVAIL and the AFFIRM trial, which I just quoted here. So if you want to read the study, which showed that either you were using this agent again in the pre or the post chemotherapy space, the patients benefited. Now, what about immunotherapy? Immunotherapy, as you see here with immune, when you use chemotherapy, here is the time to death, and here's the burden of disease. As you'd see, as the burden of disease starts, it will just, if it grows this fast, then the patient's time to death will be quite short. Now, when you give chemotherapy, as you see with this red line, what you're doing is that you're preventing, instead of the disease growing like this, you beat it down, and then it comes back, but then it becomes resistant to chemotherapy, and it grows like this, and ultimately lead to death. Now, immunotherapy, the relationship between immunotherapy and cancer is a little bit different from when you use cytotoxic chemotherapy. And this is because immunotherapy would take time to work. And as you see with this blue line, it bends the curve, but not as sharp a drop as with chemotherapy early on. But over time, it tends to have a longer duration, than provide patients with a longer duration of response. And this is because your body has, your body's immune system, which is your cancer fighting cells par excellence, is actually training itself to do its work. And, but however, the only immunotherapy that we have application for is the Sepulcel T, which is a prostate-specific antigen, target the prostate-specific antigen phosphatase, which is present in some cancer cells. And then usually what would happen, as we see here, is that, you would take the patient's blood, present it to the antigen presenting cells, express the PAP, and then train it to be able to recognize those cells, and then you infuse it in the patient population alone. The particular patient that you took this blood sample from. And this was the impact study that showed an overall survival benefit. Again, this is only in low burden disease who are castrate resistant. Very expensive study, very expensive trial, very expensive treatment, and I'm not sure that it would even be available in most places in Africa other than probably maybe South Africa. I don't know about Egypt and Nigeria, where some of these things may be available, but completely out of the reach of patients. And radium-223 in the SIMCA trial and published in this New England Journal of Medicine article actually did show also, this is a radioligand, and the whole idea behind this is that, you infuse radium, it goes and sits really in the place where the bone activity as a result of the metastatic prostate cancer to the bone is actually increasing turnover, and it goes and sits there and then start emitting small radiation wave, and which actually kills the cancer. And as you can see here, it did improve overall survival in this patient population, and also prevent skeletal related events. And by skeletal related events, we mean things like pain and fractures. The most recent kid in the block is this lutetium 177, or the Pluvicto that I talked about, and this is the Vision trial, which actually shows both progression-free survival, overall survival, and again improvement in time to first skeletal events, like we did discuss. And the whole idea behind this is that the prostate-specific membrane antigen, or PSMA, is expressed in most cancer patients and most prostate cancer patients. And then this lutetium, it's a radioligand that has been engineered, to come, dock on that PSMA and the prostate-specific membrane antigen receptor, and then it takes it in. And once it gets in, because the conditions within the cells are different from extracellular conditions, and it can actually release itself, and then the cancer is killed by this radio waves. Here we will give it once every 6 weeks for a total of 6 cycles, and some of the results have been really incredibly favorable. The problem with this is that, as I've seen it in the clinic in my own patients, the duration, the time, I mean, the patients respond very well, but then the disease comes back. Now, I just wanted to come back to this immune therapy. And if you see prostate cancer, this is a Nature paper looking at what we call the mutational tumor mutational burden, and the higher the tumor mutational burden, the more responsive they may be to immunotherapy. If you see with prostate cancer here, it's not a disease that has a very, very high mutation burden. And so it's not a surprise that it doesn't really respond very well to checkpoint inhibitor. In fact, the response rate to checkpoint inhibitor is about 5%. And this is mostly in patients who have the so-called MSI, or microsatellite instability high. If you have one of those, again, if you have the ability to do the genomics, those patients can respond incredibly well and for a long duration of time. And I did talk to you again about this DNA repair pathway mutations, which occurs in prostate cancer, for which we can use PARP inhibitors. And this was one of the very first papers. All of these are different DNA repair pathway inhibitors. But as you can see, unlike breast cancer, BRCA2 here is the most predominant one. And it happens to be the one that drives the most responses. Here's other precision medicine, the way we start thinking about castrate-resistant prostate cancer in the future. BRCA, we use PARP inhibitors. And in this case, some of the studies that have been looking at this now show that if you use PARP inhibitors along with secondary androgen pathway inhibitors such as abiraterone or enzalutamide, that combining those two provide a much longer duration of response than just the PARP inhibitor or the androgen pathway inhibitors by themselves in the patients with these particular mutations. There was a study that suggested that the patients without the mutations may also benefit, but that study is probably an outlier. The CDK4 or patients with MSI high may respond to checkpoint inhibitors. And then these other PTEN, PI3K are still really investigational, as are CAR T cells. One cautionary note: as you give people androgen deprivation therapy, remember that the result, it comes at a price, whether it be cognitive mood changes such as depression, emotional lability, or metabolic changes, diabetes, hypertension, systemic changes such as hot flashes, weight gain, fatigue, or physical changes, gynecomastia, hair loss, physiologic anemia, skeletal changes, bone loss, and sexual dysfunction, of course, loss of libido and erectile dysfunction. So remember that these people actually are going through a lot, and then you need to support them. And this is where the whole concept of whether or not you can do intermittent therapy really to give them some time off to recharge, so to speak. But then the intermittent versus continuous therapy. In the old days, if you look at old literature, it would say that continuous therapy is preferable. That may still be true for young patients, but in older patients, may not really be true. And also that is in the days when we used to use ADT alone. And so probably with more enhanced, treatment options now, as were shown by the recent EMBAC study using enzalutamide, albeit in the biochemical relapse space, that if you really do it really judiciously, where you monitor the PSA closely and resume treatment when when necessary, that the patients could really benefit from being off for a while, to be able to get their kind of again rebuild some of their lost functionality. And again, I talked about remember prostate cancer, and it's really a big problem with bone. So either it is directly metastatic to the bone, as we see in 70% of the patient, and therefore could cause bone fracture, or you cut off androgen or testosterone, and then the bones become osteoporotic, and therefore leading to increased fracture. Which means as you treat these patients, be careful, be aware of this. And I just put here just the RAN ligand cycle to show you how this the biphosphonate, how those happen. I mean, how that affect bone and then to show you with radium-223 again how it worked and why it is good for bones. But I just wanted to complete with this to show you that as you do this, always remember that wherever possible, you should be able to, especially with patients with castrate-resistant prostate cancer who are, still undergoing lifelong therapy. Remember, if you have zoledronic acid, please use it. Or if you have access to denosumab, which is a RAN ligand inhibitor, please use it. But one of the things to think about this is that the problem with this, of course, one of the things to think about, it complication is what we call the osteonecrosis of the jaw. For whatever reasons, these two medications, either denosumab or zoledronic acid, they may cause disrupt blood supply to the jawbone, and therefore cause osteonecrosis of the jaw, which typically manifests as pain. So in this part of the world, what we'll do is we'll have a dentist actually evaluate the patient's teeth, and if there are some that need to be extracted or any dental work that needs to be done, we have them done and then allow it to heal probably about 6-8 weeks later before we start this medication. And I just wanted to leave this as a take home, that the doublet therapy is now the standard of care. Triple therapy may be beneficial in patients with high volume disease, wherever PSMA or Pluvicto, prolonged survivor in metastatic castrate-resistant prostate cancer who have PSMA avid disease, adding additional abiraterone to docetaxel, as we see here, again, really improve overall survivor, and use bone protective agents. And if you're in a place where you have adequate facilities to use radiation therapy, SBRT, you could consider radiating some of the bone lesions in low burden bone disease, and also consider treating the primary if it is possible, and then wherever possible, genomic profiling to be able to get those androgen, those mutations such as the BRCA or DNA repair pathways that you can use PARP inhibitors. And and sometimes in this part of the world, African Americans, a lot of the data that we get is from predominantly from Caucasian population, despite the fact that we do have, this is a disease that really affect a lot more African Americans than Caucasians, and then by extension Blacks. And I use this also to just give you some idea about, different regimens and then their differences in the overall responses and hazard ratio. So I switch within for the next 10 minutes or so, just divide it into for metastatic urothelial cancer. And again, for here, you will have MVAC, just list out here the treatments that are available, either the carboplatin, cisplatin plus gem or carbo plus gem in the metastatic setting. Remember, in the neoadjuvant setting, carbo doesn't really have activity, or the MVAC, which used to be used before, but dose-dense MVAC. If you're using dose-dense MVAC, be sure to support the patients with growth factor inhibitors. And then more, for us here in this part of the world, and enfortumab plus pembrolizumab, it's really now our first standard of care. Immunotherapy alone is useful in certain circumstances, especially in the frail people. Sacituzumab, govitecan, and enfortumab, these are all what we'll call the antibody drug conjugate, enfortumab targeting Nectin-4 and sacituzumab start targeting TROP2. Edafitinib, it's one of the drugs that targets the FGFR inhibitor and mutation that is seen in about probably, I would say, about 10-15% of the patients. And wherever possible, genomics should be done also to help you guide your treatment. I know this, in Africa, there are not many places where you would have this, but clinical trial, wherever possible, enroll the patients. And then usually, we now have HER2 positive trastuzumab deruxtecan, which is also another antibody drug conjugate for patients with HER2. And so here is how I would select patients. If the patient is eligible for, enfortumab again in this part of the world, yes, if we would then give them enfortumab plus pembro as our first line option here. But if they are not, then you start looking at all of these criteria, their performance status, creatinine, and then do they have history of neuropathy? If all of this is, they have a good creatinine that would allow them to get cisplatin, then you can consider nivolumab plus gem and cisplatin, and then followed by maintenance nivolumab. And then, but if not, if you don't have nivolumab, you do a combination of cisplatin plus gem. It is better tolerated than the MVAC, but dose than MVAC with probably with growth factor support may just be as well tolerated as the gem-cis. The studies that really show that gem-cis was better tolerated were done with the traditional MVAC and not the dose-dense MVAC. Once a progress on all of these, some other cytotoxic chemotherapy that have activity, maybe paclitaxel, and so on. And then if they are not eligible for cisplatin, then substitute the cisplatin for cabo, or if they are older and frail. One thing I should note is that cabo is a little bit more myelosuppressive than cyst. But even though cyst is more nephrotoxic and so cabo may be considered. And I just wanted to show you, put up some studies here to show you sacituzumab, how, the data that showed. One of the things I should mention here, though, that is the Trophy 1 study, which showed this was a phase 2 study. And I think one of the study, the Trophy 4 also, which is a phase 3 study, may not be showing us as much benefit in the first line as we've had hoped it will. So it's now still something that I would reserve as second or even third line. the EV302 was the pembro and photomap study. And you see here last year at ESMO when this data was presented showing this incredible response and overall survivor, it led to a very standing ovation amongst patients because this represented a really, really good progress in our patient population. And I did talk to you about the nivolumab plus gem plus cis followed versus cisgem. You can see here the addition of nivolumab to cisgem actually improved overall survivor. And the keynote was the one that did pembro alone versus chemotherapy in the second setting or for people who were either platinum ineligible or refused. And with that patient, the overall response rate is about 20 to 30%. And you can see some of the responses could be really durable. And afatinib, this mentioned, this is for patients with a particular mutations. If you don't have the particular mutation, you should not be using this drug. Yeah, so just last 5 minutes, metastatic clear cell, renal cell cancer. So you see here, this is the way I look at it. What is the patient's performance score? If they had a nephrectomy before, is it more than 1 year? What is their hemoglobin? What is their calcium? What is their neutrophil count? What are their platelets? This is the so-called IMDC restratification. If they have zero risk, they have favorable risk, and then you look at their disease burden. If they have limited disease burden, then sometimes you can just do an anti-angiogenic therapy alone. I'm going to show you, but you could also consider nivolumab or pembrolizumab alone. But if they have substantial burden of disease, these are the preferred option, either pembro plus axitinib, nivo plus cabo, lenvatinib plus pembro. These are all TKIs plus an immunotherapy or these other options. But if they are high risk, you could do EP-nivo and or the other regimens that we have. And just this, you can look at this on the NCCN. What my attention should be, I just wanted to draw your attention to this other group that we call the non-clear cell, which are like people with other types of kidney cancer, like the papillary. All the data that we have, almost I should say, is actually derived from the patients with clear cell, but then you can apply the same data, the same logic to patients with the non-clear cell, with a few exceptions that are listed here. Again, just wanted to compare so you can see in terms of the responses. These are all the different studies that have been done. Checkmate 214 used EP-nivo, and Javelin was EP-axitinib. Checkmate 9ER was cabo-nivo, and Keynote 426 was axi-pembro, and then the clear was pembro-lenvatinib. As you see here, that these patients all have a significantly high progression-free survivor. And then they have, but the responses with the pembro-lenvatinib was about 71%. But even though with EP-nivo, the responses are just about 40%. But the thing is, if one of the things that you see, and some of the patients have complete responses with EP-nivo, the appeal is still that there are some of these patients, as we see in our own hands, who after treatment, you take them off treatment after they have complete responses. And some of them have been 7 years, 8 years out now and are responding, and are just continuing to respond without further treatment. And then, of course, here's just the last 2 slides, just looking at the pathways of how we block. Kidney cancer is very dependent on the VEGF pathway, which is where a lot of the TKIs work. And of course, the mTOR, which is where the mTOR inhibitor, everolimus, would work. And then lastly, think I might have missed a thing on the checkpoint inhibitors, the slide on the checkpoint inhibitors, but that's not a problem. And in the clinic now, we're also having a HIF2 alpha, we now have belzutifan, which is a HIF2 alpha that we do use in the clinic. Lastly, if one of the key things with kidney cancer is, I know probably again, checkpoint inhibitors are really not, may not be available or maybe accessible in many places in Africa. Just remember that the TKIs that are available, you can use anyone interchangeably. So if a patient progresses on lenvatinib, if you started out with lenvatinib and the progress, you can also still use, you can switch them to axitinib, and if the progress, switch them to cabozantinib. The progress, even if you have pazopanib or now increasingly tivozanib, all of these, there is no way in kidney cancer to actually tell which particular TKI patients are going to respond to. So I stopped there and I left you on my, I'm going to forward the slides to Dr. Bioki, who will forward them to you. And I know we've run a little bit over time because of the, the me being technologically challenged early on and not being able to put my slides, but I put my the email, you have our email, but I've put my cell phone there for those of you actually in the continent with, and you have access to me through WhatsApp if you need any assistance or any questions. Thanks.
Thank you, Dr. Fulfack, for a very comprehensive talk on GU cancers and updates. Appreciate your time very much. Esha2 will put in a link for your evaluation for the audience, and we'd appreciate if you could complete those. We will be circulating the slides from all 6 talks very shortly. The one thing to, and just to make a comment here, the field of GU cancers, especially advanced, is moving into the immunotherapy space, and just looking at resource-limited settings. There's a recent paper out in Frontiers and JCO Global that really highlights the need for initiatives to advance immunotherapy efforts on the African continent, and this is something that Global One Health is actively engaged with, and in fact, we'll be traveling to Addis next month to meet with the Minister of Health and discuss strategies on how to best do this. So hopefully more to come with that soon. But just thought I'd throw that out there. Edmund, thank you so much for an outstanding talk. And thank you to Esha2 for organizing this Summer Institute Internal Medicine series. We'll be doing this again next year. We'll be soliciting your input for ways to improve this and new topics. And we thank our attendees for being here for these last 2 days. So again, thanks everyone. Have a great rest of your day and take care.